lead EKG. Now let's talk about what we see on that 12 lead EKG. And the first thing to interpreting a 12 lead EKG is to start with your EKG rate. We know that our SA node, which we talked about when we looked at electrical conductivity, is the heart's pacemaker. So that normally beats at about 60 to 100 beats per minute, or it sends that impulse at 60 to 100 beats per minute, which causes our heart rate. Anything that is slower than that, regardless of what the rhythm is called bradycardia. Anything faster than 100, we call a tachycardia. It's very simple. And we have other pacemakers in our heart that can kick in if the SA node is failing or not working as it should. So if you look at this picture, it's showing you we have our SA node at the top, but sometimes other foci may kick in the atrium. And this may keep our rate at 60 to 100, or usually about 60 to 80, but you'll see that the P wave looks different, or maybe the rate is a little bit different, and that clues you in that it's coming from another foci. Now, if that doesn't work, then our AV junction will kick in, and then we'll beat at about 40 to 60 per minute. And if that doesn't work, then we'll go all the way down to our ventricles, and then we pace at about 20 to 40 beats per minute. And the way our body was designed, we will suppress anything below. So if your AV junction is firing, then the ventricles will not be firing. These are some backups that are built into our heart to help keep our pacemaker firing. So there's some pretty easy ways to determine the rate. And the best way that I can tell you is to take a look at this EKG that you see in front of you and memorize these numbers, okay? We're gonna find an R wave that falls on a heavy dark line. So if you look at this EKG in front of you, let me see. We're gonna find that R wave, and you see where it says start here. It's gotta fall on a heavy dark line for this to work. You're gonna memorize these numbers: 300, 150, 100, 75, 60, 50. All right? And then you're going to count. So the next heavy black line you see is 300. Then we have 150. Then we have 100. Then we have 75. And we have 60. And ours is falling somewhere in between 60 and 75, right? So we can say that our heart rate on this patient is about 70 maybe. And it doesn't matter if 70, 72, it doesn't have to be exact. You just want to know if you're dealing with a regular rhythm, a bradycardic rhythm, or a tachycardic rhythm. Another way that works really well with slow rhythms is to mark a 6-second strip. And what that means is, if you look at this EKG paper, it's not so easy on the top one, but if you look at the middle one and the bottom one, you see those little black lines at the top? Those are marking 3-second strips. Okay, so 2 of those, if you see the 3 of them, is a 6-second strip. So we want to count how many R waves, which is the QRS complex, that we see in a 6-second strip. Whoops, let me go back. So if you look, in the bottom one, I see 1, 2, 3, 4. I'm going to multiply that by 10. You're always going to multiply by 10, and that's going to tell me that that rate is about 40. It works better with slow rhythms than fast, but we can do it with a fast rhythm as well. You see this one on the top? I'm going to count 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13. So I'm going to say this rate is probably about 130. And it's a pretty accurate way to determine your rate if you want to look at something really quick. Now let's touch upon rhythm. We're going to look at some of the arrhythmias. We're going to look at some irregular rhythms, premature beats, tachyarrhythmias, and some blocks. And the most important thing with recognizing rhythms is realizing that there's patterns. Start to recognize the patterns. It'll make it much easier. Let's start with the pattern of a normal rhythm. A normal rhythm should have equal distance between similar waves. So that means from every QRS complex to the next, it should be the same distance. Every P wave should be equal distance apart. Every T wave should be equal distance apart. Normal intervals, and your rate, again, remember, is normal, 60 to 100 beats per minute. Normal sinus rhythm. Well, what is this rhythm? So we start, the most important thing is to start, we can look at our rate, right? It's a little hard to count this rate because it's irregular, and irregular starts to clue you in on something. So the next thing you want to look at is there a P wave, a distinct P wave? Well, in this case, I don't see a distinct P wave. I see a very jagged baseline. And this is because there is rapid firing of multiple foci going on up in those atrium. So they're just firing, and every once in a while, one of those impulses gets through and causes a QRS complex. But it's random, right? So you have that irregular rhythm. There's no P waves. It's irregularly irregular, and we call this atrial fibrillation. Okay? Very common arrhythmia. What about this one? This one looks a little more regular, and look at our baseline. Our baseline has a very jagged, almost sawtooth appearance to it. This is very classic rhythm that usually will degenerate into atrial fibrillation in time. It's like atrial fibrillation. It can lead to blood clots, so these patients should be anticoagulated, and we call this atrial flutter. Here we have some PACs, and PACs are premature beats that come from an irritable foci producing a beat that's earlier than expected. So that can be in a bigeminy pattern or a trigeminy pattern, like every 2, every 3. But you see there's a distinct pattern if you look at the second EKG. And sometimes it can just simply be non-conducted if you look at the third one. But it's important to distinguish that this is different. If you look at the top EKG, it's different than atrial fibrillation. Even though when you first glance at it, you may say it's a little bit irregular because of that PAC, but you see there are P waves in front of every complex, okay? That's a clue in that this is not atrial fibrillation. This is either a non-conducted or a premature beat. Okay, how about this one? I put this EKG here because this is something that is very common with the older population, and particularly in this region of the country where we have a lot of smokers and a lot of COPD. This is very commonly seen in COPD. And you see that there's some P waves, but they're kind of all looking a little different, and you might even look at that again and think, is that atrial fibrillation? What is that? But there are P waves. This does not require anticoagulation. This is from COPD, and the treatment for this arrhythmia is to treat the COPD. We call this multifocal, so it's coming from different foci in the atrium, tachycardia. So it's a fast rhythm with very different looking P waves, right? And that we call that multifocal atrial tachycardia. So very common up here. When you see it, the treatment is to treat the underlying COPD. Okay, so here we're looking at some unifocal and multifocal PVCs. So again, these are coming from foci within the ventricles. They're going to produce that large QRS complex, and depending on if it's the same foci or different foci, these are going to look either very similar or very different. So you can see the bottom, we have foci coming from different areas of the ventricles. And again, they're going to be a premature beat. They're going to have that wide looking complex, very different from your other QRSs. These are usually benign if they're just periodic, and usually there's nothing to treat in a normal healthy person. It's very common to get an occasional PVC. However, again, it's always important to look at your patient. It also can be caused from poor oxygenation, mitral valve prolapse, hypokalemia, and if you were at intensives, we talked about potassium when I did the basic metabolic profile and how critical that is to your cardiac arrhythmias. And I will try to put an example of a 12-lead EKG or some kind of electrocardiogram with elevated potassium so you can see the changes in the T waves. Okay, here's another rhythm for you. This one looks like it's tachycardic because I can find an R wave and I can tell that I'm looking at about 300, 150, 150, somewhere in there, 160. Actually, it's reading at 180 on that strip. But it's narrow. So if it's narrow, remember our PVCs, our premature ventricular beats, have that wide look to them. These are very narrow. So this tells us this is coming above the ventricles. It's coming from a foci of some kind, and it's fast. It's not the SA node. So this could be premature atrial tach. This could be premature junctional tach. We don't really know. It's going so fast that we can't even determine. So we call this a general term of supraventricular, above the ventricles, tachycardia. And again, this can be caused from COPD, someone with heart failure, and there's medications that can induce this as well. How about this one? Fast again. Find a black line, 300, 150. We're going above 100. This is a tachycardia of some kind, and it's wide. So that should already clue you in. Looks like runs of PVCs, right? This is very often indicates cardiac insufficiency. And it's important to distinguish between a wide QRS complex SVT versus a VT, okay? Because if this is a ventricular tachycardia and you treat it with medications for SVT, you can progress this patient into VFib. So the pearl I have for you here, if it is a wide complex tachycardia and you don't know what it is, treat it with amiodarone because it will treat both, okay? You don't want to give something like adenosine to somebody who's in VT. So think wide complex amiodarone. You can't go wrong. And again, of course, if they're unstable, you're going to shock them. But I'm talking about a stable, wide complex amiodarone. Treat it as VTAC. How about these? This is what VTAC can lead into, right? Ventricular fibrillation. One foci firing at an extremely rapid rate, 250 to 350 times per minute. There is not enough time when that's happening for your ventricles to fill. So you are going to, this patient is decompensated, completely decompensated. The treatment for this is to cardiovert. I'm sorry, not to cardiovert, to defibrillate. This requires immediate defibrillation. So VFib is what you see in the middle there. And the bottom one is torsades, which also requires immediate defibrillation. And when these are happening, there is just no pumping going on in the heart. You are perfusing nothing. So you have very little time to get that heart back pumping effectively. So again, top one is V flutter leading into VFib, and then the bottom one